This conference will now be recorded.
Okay, good evening, everybody. This is Rick Davis in deep southern Arizona. Soon to be in Houston for the balance of the week. I want to thank our sponsors, who are Bayer, Johnson and Johnson, Telix, Blue Earth. Go and help me. I should put it up in
Myriad.
front. There's a
Myriad.
Myriad and one more for Foundation Medicine, right? So thank you. We're going to be meeting with two prospective sponsors in Houston as well, so we'll see how we do. We've got a lot of people who want time tonight. That's probably because we missed last week. If you didn't watch the clinical trials webinar, it's definitely worth a watch. Maybe somebody can put the link in the chat window. It was in the reminder. Dr. Wendy Garvin Mayo said every patient should watch this. And some of our people who are here had some very good questions, including my fratello Leonardo Sierra, who put in a couple of great questions. And I hope the answers were as good as the questions, but I'm not sure.
I dropped off after an hour and a half. I never got the answers.
Oh, well, then you'll have to watch through the recording after an hour and a half. But we did respond to your questions.
Okay, great. I'll do that.
Before we start today, sadly we have more sad news, and that is that we lost a very well-respected AnCan this past week, Dr. Bob Gamankin. Very sad. I will write something up. Len, would you were the one who informed me about it, so would you just like to say a couple of words? I'm not sure how you found out, but maybe you could say a couple of
Actually,
words.
I found out through Peter, but yeah, I had spoken to him about a week before he passed, and he was in home hospice. He was on heavy opioid doses and oxygen, and I could tell I didn't keep him on for longer than 10 minutes because I could feel his energy just draining as we spoke.
Mm.
But Bob was a gentle soul. I really loved the guy, always willing to help anybody, despite all the difficulties he was having himself, all of the failed treatments. Um, and we actually spoke a lot about not the last call, but prior to that, we spoke a lot about ketamine and the insights that that might provide. Bob had 2 sessions of ketamine with a pharmacologist, and he felt he got some valuable insights, and it reduced his anxiety about death and dying. So, well, I don't know what to say. I'll miss him. He was a really super nice guy.
Yeah. The one thing I will say, and I'll say a little more, is that Dr. Bob tried to enter a trial, the ARV-766 trial in the last few months. He had the right, as I recall, he did have the right mutations of his androgen receptor, and I think he might have started, but he dropped off. And at the time, Arvinas got a report from FMI which I have a copy of, and I think Len had a copy of it. I will say I have never, ever seen so many mutations as there were on that report. I'll count them up and let everybody know, but there had to be 20 or 30 mutations on that report, including several tumor growth suppressors. And so I don't have an earlier report from him, so I don't know how many of those came later in the disease. He did have a report done earlier in the process, but I never had a copy of that. So and it reported no mutations, so which was kind of strange. And we questioned it at the time, but I don't know if he got it redone earlier. But I think he was faced with very difficult disease from the outset, because he was only diagnosed 24 months earlier. So I think the deck was stacked against him from the beginning. So anyway, he will be missed, and for sure his memory will always be a blessing to us at AnCan. So, okay. Sorry to start off with news like that, but I know you guys will want to know. Mark Valens, we're going to go to you first.
Well, just a little bit of a update. I'm back to where I was just a year ago. My PSA had been less than 0.01 for a long time, and then it went up. It went up to 0.01, and then up to 0.02. It seems to be climbing a little bit. Just last year when I went through this, we wanted to let it climb enough to get a PSMA scan, which then showed that the cancer had come back and that I had a bone metastasis. I'm just wondering if I should do the same thing and just let it keep growing, or whether there's some reason to get in sooner with something. So I wonder if you had any thoughts about that.
Well, let's just clarify. I thought that right now you are taking darolutamide. Is that correct?
No, that didn't work very well for me, so I'm back on Xtandi.
Okay.
Lupron and Xtandi.
Okay, so right now you're doing Lupron and Xtandi, correct?
Yes.
Well,
I mean, I think it's too early to do anything, but it just feels so familiar to what happened a year ago.
I don't know. There's a lot more that you could do right now, without, I mean, chemotherapy. And you've done chemo before, correct?
No, never done chemo.
Well, you've never done chemo. Well, that's something that you should be considering, because right now we still don't, even though the PSMA4 reported, you still need to have done chemo if you want to get to Provenge. So then that might change if they get the PSMA4 reported decent results. But then we also saw at GU ASCO a poster that said that you get better results if you've done chemo before you do Provenge. So you get more mileage out of the sorry, not Provenge, Pluvicto. I meant to say Pluvicto, but Pluvicto is is in your future, but you'll have to have done chemo first. So that is a discussion. I kind of think that when you're vacillating between zero point zero 0.01 and zero point zero 0.02, you really need stronger evidence because that's within the margin of error of the test. So you don't really know.
I understand that, and that's just what the doctors were telling me last year, and then it was 0.06, and then it just kept going up, and so I don't think I'm not planning to do anything yet, but got to watch it, and it's something may be coming before long, and one thing that's different is I'm super exhausted now. I sleep 6 to 8 hours at night and then sleep another 2 to 4 hours during the day. And I didn't have that before.
How about the Adderall? Is it making a difference?
I think it's helping. It gives me a little more of an oomph. And I'm taking it 5 days a week. The doctor says I need to take a little break. So, but I get a little more done, I think, when I take it.
So let me ask the group if they have any input for you on what they would do in your situation. Anybody want to speak up? Best to if you David, fine, and if you can raise your hands, that would help me. But David, please go ahead. You're muted right now.
Yeah, Xtandi knocked the shit out of me, Mark. I mean, it was a very tough drug for me personally, and maybe it's the Xtandi. Maybe you want to think about you. I heard you could go on darolutamide, but maybe there's another drug you can take. But Xtandi was just, I mean, it put me out.
Yeah, I'd taken Xtandi, for before, a couple years ago, and it was tough, but I could handle it. So we tried darolutamide, and that knocked me flat. So I went
Yeah.
back to.
Dr. John?
Is my mic working?
Yes.
Yes.
Oh, good.
Hooray.
I wanted to ask you, Mark, last year when this was happening, were you off all medications that time around, or were you also on ADT that time around too?
No, I had been on a total drug holiday for over
Hmm.
a year.
Okay, I understand. So it's a little bit different of a game now.
Yeah.
Yeah, I don't know really what the time is to pull the trigger on chemo or whatever the next step is at what PSA. I don't know. I did remember though that a couple of months ago we were talking and you got opposite information from me and a nutritionist that you were talking to or listening to a lecture on, whereas I told you fermented foods were good and she told you fermented foods were bad. And then Rick was going to set up the battle of the century for us, and I think it got left by the wayside. Do we still want to bother to do that?
To discuss fermented foods? Yes, by all means.
All right. I mean, Mark's got bigger worries right now, but sure, if you still want to do that, Rick, you have to put me together with that nutritionist.
Greta.
Oh, right. Okay, so I was supposed to introduce you to Greta and I forgot. Okay, that's funny enough. I was talking about Greta just this week.
Oh,
Greta, I'm making a note, and Dr. John Ray, fermented foods. Funnily enough, I had something again on the radio. Can't remember what show it was. Probably about the benefit of fermented foods. So that would be a vote in favor of Dr. John. But I
two to
had
one,
forgotten.
2 against 1 right now. We'll see how it
Yeah,
goes.
yeah, yeah. Anybody else have any quick input on fermented foods before we move on?
I agree with Dr. John as well. So 3-1.
Okay, thank you, Dr. John Ayo.
When you say good for what? What are you talking about? I missed the drift. In general, good? You mean good for your
Yeah,
health?
in general, good. In general,
Yeah,
good.
in
When
general,
I
good for
argued in favor of fermented foods, it was fermented foods as probiotics that were good
absolutely,
for our intestinal microbiome and all the various things that seem to be connected to the intestinal
absolutely,
microbiome.
absolutely. I agree. Kimchi, sauerkraut, I do it all the time.
Pickles.
Fermented pickles, they're good too.
Yeah.
Okay, Rick,
No.
thanks. I just wanted to put it out there.
Okay,
And
we're moving. I guess we got to move on because we do have a lot of people. Frank
yep.
Babish, go ahead, please.
Thank you. Um, I was in to see my oncologist this past week. He had stopped my Pluvicto treatment after 2 infusions because my PSA had gone from 3 to 32. So it was very apparent that it wasn't working. Um, and so he recommended to me to move on to a PARP inhibitor, olaparib, and Rick had recommended that I be somatic tested again to make sure that I still had the BRCA2 gene, which was required to go on to the PARP inhibitor. I was checked about just over a year ago, and it found that I had 5 somatic mutations. This second time around, it had dropped from 5 to 3. And I got the report back from Tempest, and it showed I still had the BRCA2, I still had the P10, and then I had a CTN NB1. And I have no idea what that mutation is. So the other thing they reported back, which was a bit high, was that my blood tumor burden was 21.7. So I've been on, since I still had the BRCA2, I've been on the PARP inhibitor since July the 10th. I went in on the 29th to my doc, blood draw, and my PSA didn't go down, but it only went from 32 to 39. So my doc was pleased that it didn't jump like it did on the Pluvicto, and he thinks that once I have the next appointment in 4 weeks, the end of August, that he expects that the PSA may level off or go down, but we'll see where it goes. The blood count was a little bit off. Um, my white blood count was 8.63. My red was 2.7, and my hemoglobin was 9.7. So all three went down for the 20 days of treatment on the PARP inhibitor. So they're going to be watching that, and that's why I'm going in every 4 weeks. So I'm hoping I got half good news on this last appointment. I'm hoping for pretty good news the end of the month.
Okay. Well, I'm really glad that they did the NGS again because I just think it's so important, and it's possible that that combination of BRCA2 and P10 might have gotten in the way of the Pluvicto because at the same time BRCA2 2 is supposed to be good with Pluvicto, and P10 is supposed to be bad, so I'm not really sure. CCNNB1 I have seen before, but I know nothing about it. So when I throw this open in a minute, if anybody does, please speak up. The TMB 21.7 is really high, and there are some docs we work with who would consider that that is definitely sufficient for you to get Keytruda or pembrolizumab or a similar anti PD-1 drug. So that's another thing that might be helpful for you. What was your MSI? Was it high, regular, or low?
It was. I don't believe it was out of line.
Okay, it wasn't MSI high.
No.
Okay, so you weren't MSI high, because if you had a TMB of 21.7 and you were MSI high, that would really be a good indicator for immunotherapy. Definitely.
My doc did say what you just said is with the high tumor burden, Keytruda would come into play if the PARP inhibitor isn't effective.
Right. So, but do watch those blood counts. They're doing the right thing. And, the other thing is that when you start getting low blood counts, if you get, and I'm parroting Dr. John here because he just coached me on this over the weekend, but if you start to feel any sort of infection or fever or anything like that, report it right away, because your blood counts, that red blood count's pretty low. There's a little bit of room in the others, but the red blood count is pretty low. So, all right, let me throw it out to anybody who would like to say anything to you. Don't all shout at once.
Rick, I did a quick lookup of CTNNB1. Apparently, it's a fairly rare mutation in prostate cancer, and it activates signaling pathways that lead to cancerous growth, progression of the cancer, but it's not an actionable gene,
Okay.
actionable target mutation.
Yes, and now I remember where I just saw it. Al Latimer has that same mutation. So I knew I'd just seen it recently. So that's where I'm getting it from. Anyone else have anything for Frank before we move along? And thanks for looking it up, Len. Appreciate it.
Thanks, Len.
Sure.
And when I next speak to Al Latimer, I'll ask him if he has any information on it for you, Frank, or you can drop him a line if you want to drop him a line, ask him if he knows anything more about it. See what Dr. Schultz might have said to him about that CTNNB1. But yeah. Okay, we got a lot of people, so we'll keep moving. And Richard Craymond, you're up next.
I'll make it real quick. My 3-month scans, the CT and the whole bone is, as usual, totally clear. The CT this time showed lymph nodes in the pelvis actually reducing in size, not a lot, like major axis, 1 millimeter, well, on all the axes, about 1 millimeter. And the lung metastases, the what are they called? The individual indicator nodes remain the same. Number of nodes uh, basically remain the same, or they may have reduced. Um, I say that because there's so many of them. Every time they count them, they uh, get a slightly different count. So everything is basically going. I've been on holiday for a couple of weeks from the chemo, and we're going to try that for another 2 months. Um, basically, I'll just stick with the ADD. That's all I've got.
Okay, so for those of you who don't know, Richard has a very rare type of prostate cancer called foamy gland adenocarcinoma, prostate adenocarcinoma, which is very rare. I know very little about it other than Richard has it, and
Not many people do know anything.
That's right, and Dr. Epstein has rarely seen it, but he's reported it. And he's on cabazitaxel, which has been holding him nicely, and he's been tolerating it fairly well. So it's good to hear. And let's. Will you be testing along the way since you're taking a chemo break, Richard?
Yeah, Dr. Allen's moved up the when I'll get the next scans. They're really, PSA is useless.
Yep.
Never gets above 0 now. And same with testosterone. And so the scans are the indicators.
Yeah.
And the one thing I say about the CT scans, with all of the lung nodes involved, uh, the airways have not been involved at all. It's only been the lobes themselves. So
Right. And what I should also tell the group is that this foamy gland is not particularly PSMA avid, so PSMA scans don't tell us anything.
well, when I had that, the lymph nodes lit up like a Christmas tree, but the nodes in the lungs were totally black.
Yeah.
Um, I see Dr. Markowski. When is it? Thursday, the 8th now, and see if he's come up with anything now. And so far, I'm just marching along. I need to get more exercise, like a lot of people. And I don't know who said it about sleeping 6 hours and at night and then taking a 2-3 hour nap. That's normal.
Okay. Well, the exercise is within your own control, And we strongly recommend that you try and find some sort of exercise that you are comfortable with that you can do every day, Richard.
Yeah.
It's really, really important to help you out. By the way, our exercise guru is in the Shenandoah Mountains for the month of August, but he'll probably listen to the recording. So we acknowledge Jimmy in his absence. But yes, that would be a good thing to try and get yourself into a solid exercise program. Okay.
Brief question.
Yes,
Very
sir.
quick question. Yes. Richard, are you, the CT scans you're taking are just plain with no contrast?
With contrast.
What kind of contrast?
I assume it, like barium, it tastes like that.
Gadolinium. Okay.
Is it gadolinium? Does that ring a bell?
Not recently.
Okay.
I will go check because I've got it obviously.
No
Okay.
problem.
I don't have it in front of me,
Thank you, Richard.
Okay.
but they do tell me what type.
Okay. All right. Moving on down the list, Joe Commander.
I'm probably going to start hormone therapy in the fall for the first time. And my doctor said she'd start me on first generation ADT, and we would see how that worked. And I might not need the second generation. I wonder about the thinking about that. What are the considerations about whether to try to be on both at the same time or to wait and to see if that's necessary? Do people have thoughts about that?
So we should say that you have a couple of spots that was seen on your scans, on your PSMA
Right.
scan, isn't that right?
That's right.
And where were they?
Lymph nodes in
Lymph
the
nodes.
pelvic area. I don't know. Pelvic hip, down there somewhere.
Okay, but they were definitely lymphatic, correct?
Yes.
Okay. Well, I will let other people speak and then I'll come in. But what would other people recommend?
Well,
And
this
what
is John.
questions? Yeah, go ahead, John.
I mean, correct me if I'm wrong, Len and Rick, but it seems like study after study has shown the double therapy to have better outcomes than single therapy in high risk disease. So if maybe because these nodes are just nodes in the pelvis and no bony metastasis and no visceral metastasis, they're not considering you high risk enough. I don't know, but did you remember your Gleason score?
Right. It was either 4.3 or 3.4. I think it was 4.
I have it as 4.3.
Okay, we'll go with that.
So I guess it sounds to me like it all depends on whether you would be considered as a high risk person.
Okay.
Yeah, I agree with John. I think the answer would be much clearer if you had a Gleason 8 or higher and you had metastases to the bone. Absolutely, doublet therapy, the second hormonal therapy, is called for. But in your case, it's not quite so clear, and you might very well do well on just the ADT. I'm not sure how much data there is on that.
Jim Marshall.
Yeah, yes, anyway, I was a Gleason 3-4 in 2017 in July, okay, and it was just the close of the latitude study, which happened to study that, and supposedly outcome that they contended that the median survival time would increase by about 17 months. And so at that point, I got put on to Lupron plus, okay, abiraterone, and it's 5 years of treatment and 2 years of a treatment holiday, and I'm doing good. And I had it metastasized to the lymph nodes within the back, and were the large ones. And
Okay.
that's the only treatment that I've had, and it has been done well.
Yeah.
Done good.
Anyone else before I put in my 2 cents, and then we go back to talking to Joe?
Lymph nodes where? Did you say in the back of what? I didn't understand that.
In
Yeah,
the back, there are 2 large lymph nodes in the back, I understand. And I forget the name of them. It's a very long name. And they were, they found it there.
Okay, I
Were
just
they
didn't understand what.
retroperitoneal lymph nodes? Was that the name?
Yeah, right.
Okay,
Yes.
thank you.
So, if it were me, and having seen a lot, I would definitely up for the doublet. Now, I know that, Joe, you've been reluctant for many, many years to do hormone therapy, and you've tried to find every way to sort of work around it. But the fact is that the hormone therapy does work. And there was a recent approval for darolutamide with metastatic hormone sensitive. So you might be able to get the darolutamide along with the Orgovix. I would probably say you're better off starting with the abiraterone, but you're going to feel more from that than from the darolutamide. Mostly, there are exceptions like Mark Valence, but those exceptions are definitely few and far between. So if it were me, if your doctor is responding to you by saying, well, we could start with one, that's fair enough. If she thinks that starting with one is the best therapy, we would go back and question and say, well, you're really better off, aren't you, with doublet based on the studies? So, the ball is in your court, but if you wanted to do doublet, the insurance would pay for it, and there is reason to do it.
Yeah, I wonder if she's not trying to respond to me. And next time we talk, I'll actually ask her that. And I'm more inclined, if I'm going to do it, I might as well go whole hog, and do it. So, thank you.
We just think it pays in the long run. That's what we see. Dan Straub, you have your hand up.
Yeah, Joe, I don't know why you were reluctant. I think it was before I signed on. But in the past 2 weeks, I started both RT and HT. And the same thing these guys are talking about. And my side effects are nil, maybe because I'm running every day and working out and lifting weights. But if your concern was the side effects, I wouldn't I wouldn't give a lot of weight to that. I would do the double therapy.
Mhm.
Thank you, Dan. Okay, anyone else? Anyone else before we move along? I don't see any more hands, so we're gonna keep going. I'm pushing it along because we got a lot of people, and
Thank
we
you.
got some people who came in late, who we can get to if we get through everybody else. Julian, what do you got to tell me?
Well, last time we talked, I was talking about my testosterone being real low. It was at 75 last time, and before that was 107. It was kind of a downward trend. And I talked to Dr. E about that. He said, we need to look at the balance uh, of your vitamins that you have, and I hadn't been taking my vitamins very well, and of course I got scolded for that. So I'm taking my vitamin D religiously now, and hopefully she'll think that should balance my system out and bring me back up to where I need to be. She also took me off of metformin, didn't just that was lending any help with that. Although my glucose, my A1C is at 6.3, so we're going to ride that wave and see what happens. That's it.
How more to the point? How long have you been? How much vitamin D? How much D3 are you taking now, sir?
It's let me look real quick on the vitamin D. 12,000, I think, if I remember correctly. Yeah, it's up there.
12,000.
I
That's a
think
big. That I mean, you can, but that's a decent sized dose. How much did Dr. E suggest you take?
that's what she suggested, but it's every 3-4 days, not
Ah,
not every day.
okay. That's interesting enough.
Yeah.
Um, let me see here. I'm just looking for. Okay. Okay. Now we have a special treat since we're talking about Dr. E. Okay, I'm going to share my screen, which I'm doing right now. It's just coming up, and let me see if I can get this good, and share. Okay. Does everybody see that or not?
Yes.
Yes.
That's Dr. E in Mykonos as of last night. And if I go down the screen a little bit, there's the menu. There's a glass of wine and the menu. So God bless her. She's taking a little vacation. The reason I've been in touch with her is because I'm doing a presentation for her, and so she sent me that little note this morning, together with that really lovely picture, which we're going to try and see if we can use that somewhere. But I am looking forward to see it. She said she's coming back tomorrow for me. So Julian, maybe she'll show up. Maybe she'll show up on Wednesday
She's
Wednesday
easy on the
night.
eyes,
She said she was going to be there. She was very excited.
I guess.
All I can
I
think
didn't
of
see the
that
menu.
picture is holy moly.
Easy on the eyes.
Holy moly! Holy
Wow.
moly! That's right. I think where's Joel? Where's Joel? Joel, do you like that picture?
Yes,
Where's the
extremely nice.
general?
Extremely nice.
Was there a menu in that
Oh,
picture you said?
Did you see
yes,
the
you
menu?
weren't looking. Who was that? Somebody wasn't looking at the menu.
I didn't see it. I did not see a menu.
Okay, well, look, there is a menu down there. I'm looking at it again, and I can't tell if she's reading the menu in Greek or in English. I'll have to ask her. But she was on Mykonos, bless her. And I'll talk more about what I am presenting, but it's a little 25-minute keynote speech called "Can You Hear Us?" about listening to the patient voice, because in our view, Dr. E is one of the best docs out there in terms of hearing the patient, and responding and trying to adapt the treatment to the patient, which is huge, So, Julian, you'll let us know how you do with this vitamin D. Any
Oh yeah.
other adjustments other than the vitamin D?
Well, she took me off of the metformin, said that wasn't really helping me in any
Right,
way.
right,
And that was
right.
about it.
Well, yeah, I mean, there's been more studies that the metformin doesn't really do very much.
That's for
And then,
prostate cancer, but it's still a great drug for diabetes, and his
oh yes,
A1C is 6.3. So don't throw the bottle away.
Oh no, I
yeah,
never throw until they expire.
Yeah,
yeah. No, I mean, that's a great point. I mean, if you have it, but there are some of us in this group, like Leonardo, who have always said that metformin doesn't do much for prostate cancer unless you got diabetes. So kudos to Len. Okay, we've got a few people with their hand up. We'll get around them. Jim Marshall, first of all.
You gotta post that picture on the website. You just gotta do that for me. As a
So here's
research
what I
tool.
did. Here's what I did. Here's what I did, Captain. As soon as I got the picture, I sent it to Alexa and I said, "What a lovely picture." And Alexa said, "Yes." And I said, "Alexa, it's up to you to figure out where we put it on the website." So it's down to Alexa where we get that onto how we get that onto the website. Dr. Jeff.
Yeah, Julian, did they measure your vitamin D levels before they put you on 12,000 units every 4 days?
Yes, they did.
What was your D?
It was very low at that time when they first took it, because when I was doing my radiation treatment and taking my darolutamide and the I forgot what the other one. It dropped my vitamin D, and a lot of my vitamins went down real low. So I was on some heavy duty vitamins for a while to come up. Plus, I was exercising, which helped quite a bit to stay with me out. But one of the things she did also suggest, but it wasn't on this visit, was to take collagen, and that's really helped my bones quite a bit because they used to ache a lot at night. But I take the collagen every day, and my bones feel a lot better.
Yeah, but 12,000 every 4 days. How long have you been doing? Are you still doing that?
Yes,
And
I had dropped off. Wasn't very religious about it because it had dropped quite a bit.
like, could you tell me a number? Do you remember a number what your D level was? Was it like 10 or 20 or?
It's been low. The last time it was 26.1.
Okay. Because I mean, vitamin D is not a benign vitamin in high doses. The recommended dose for guys over 70 is between 800 international units, sometimes 1,000. 12,000 twice a week is mega doses. You could do that for a short time, but you got to
Yeah.
be careful. You wind up with kidney stones from too much vitamin D. Um, it's not like taking candy buttons.
So, yeah, I mean, you can take, this is what I've always understood, that you can take 5,000 safely if you're really low when you first get measured, and then you have to remeasure. So what I would be doing, Julian, is ask to remeasure, because once you get yourself up in that 40 to 60 range, you can start to tail off. I mean, I did that when I was diagnosed. My vitamin D was 18, and I just took fairly large doses. I didn't take 5,000, but I took fairly large doses. And then I would measure my vitamin D on a very regular basis. There are some docs that prescribe 50,000 dose once a week. We've seen that as well when you're very low. But again, what's important is to keep remeasuring until you get into that level. And I have always suggested to men that if they're taking daily vitamin D, that they measure at least once a year, so that they can correct if they're too low. If they're too high, they can make a correction. Would you agree with that, Dr. Jeff?
Yeah, I mean, I've given patients 50,000 units when they have a level of 10, but you
Yeah.
follow them. You certainly don't want to induce a hypervitamin D state, which has complications. So, yes, I would measure it. I wouldn't keep taking 12,000 twice a week without knowing what my levels are. Uh, I'm probably more than once a year, but I would want to know what it is like now.
Yeah.
That's
Yeah. I mean, I think when you're low, like you were, it's just good measure it every 2 or 3 months and just see how you're doing, Julian.
Right.
So
well, it's been on a year ago it was at 28 and it hasn't been coming up. So, I wasn't taking it religiously enough, but, now I'm taking it as she wants me to do.
And do you
okay.
do you take it with some fat
Oh
in your
yeah, I take
diet?
it with meals. Yes, with meals. I don't take it myself by any means.
Gary, what's on your mind, Mr. Peters?
Um, I wanted to ask Dr. Jeff what he recommends as the upper limit for vitamin D. And I wanted to ask Julian what else Dr. E gave him as a protocol for vitamin.
Yeah, 80 is a nice number.
Okay, thanks.
80 meaning blood level, Jeff, right?
Yeah, blood, right.
Yeah, 80 nanograms per milliliter.
Yes,
Right.
I have a range of 30 to 150.
Yeah. And
What
and
what other vitamins other than vitamin D, did she recommend that you take some others?
I take phosphorus and I take a multivitamin, and that's it.
And
yeah,
what did
I I'm
she
not a
prescribe
fan.
the fast?
Hold on a minute, Gary. Let me just respond to the multi. I'm not a fan of of multis
Exactly.
because many of the components um, in multis you may already be well up there, and you don't need more of it. And
Right.
I stopped taking a multi several years ago. I think you're better off if you know where you have a deficiency, supplementing that deficiency. I mean, if you look at the back of the multi, there's a lot of stuff in there that you probably don't need. And sometimes taking too much of something can be harmful. That's just my 2 cents on a multi. Gary, what was your follow-up question?
I agree with you about the multi, and I was going to ask Julian what the phosphorus is for.
That's
To light it, so he lights up at night. What do you think it's for? What's your phosphorus for, Julian?
my heart.
Uh,
Okay,
okay, thank you.
thank you.
Welcome.
Okay, anybody else before we move on?
Rick, I'd like to ask Jeff. I've seen vitamin D with K2. Do you know the rationale behind that combination?
I don't.
Okay.
I mean, most of
By the
us,
way, go ahead, Jeff.
no, most of us take vitamin D in association with calcium, and we do D and calcium to enhance the absorption of calcium, so we don't wind up with significant osteoporosis, fractures, things like that. I have a hard time understanding. You take D um, and phosphorus. It's an odd combination because phosphorus kind of counteracts calcium. So it's just an odd combination to me.
I could say something about K1, K2, K3, if you'd like to know. It's usually, I take it in addition to vitamin D. And what it does is it prevents the calcium from going into the heart and the arterial bed rather than the bones. And it protects the bones and keeps them calcified rather than, ending up in the artery ring with a high calcium score.
So Jack, I have a very high coronary calcium score. So it sounds like I should be taking K2 with vitamin D.
Well, you should have a long time ago been taking it, but I guess maybe you could start now.
Yeah.
I mean, we all, as we get older, we get more calcium in our arteries, but that's one of the reasons I've been taking it for a long time.
Okay,
Well,
thank you.
I could use something to get the calcium to stay in my bones and not go into my bloodstream. That I don't know if vitamin K helps with that, but that would be a useful thing certainly for me.
Well, that's
I went
what
to
it's promoted for that.
Yeah, I take K2 with vitamin D. I read about it, and they highly suggest it. So that's my 2 cents.
Okay, does the K stop it going into the bloodstream and keep it in the bones?
It's supposed to.
Yeah, that's what it's for, to help do that.
All right. Well, I'll be looking at see what vitamin K does. As it is, I shrunk another inch when I went to the doctor this week, so I'll be under the table before too long, which is not so good. But my dad did too, so but he didn't take vitamin K. I wish you would have told me that when I was 5'10" and not when I'm down to where I am. But still, I had thought of asking when I got my hips replaced to add a little there, but the trouble was they would have had to put it on one side, and then I would have been walking around with a hoik until they did the other side. So that wouldn't work too well either. Okay, we're gonna move right along. Dennis,
Hello.
speak to.
Let me get a drink of water here. Second. Yeah. First thing I'm on a drug holiday, and I know I'm getting close to where I'm going to have to do something. And I also realized I was long overdue for seeing the cardiologist. So I made an appointment, went to see him, and they did the calcium score. You guys were just talking about it. He said everything was fine. Of course, they did an echocardiogram, a sonogram, and a stress echo. And he says I was probably better than most people my age. But he didn't see any issues. I told him I was concerned about long-term use of the EDT in Zytiga for 8 years or so. So, but I don't know what's a high one, Len. And I've got a whole bunch of different scores here. There's the left main, the left anterior descending, and so on. Is there it's a total Agatston score? Is that what would be the total?
Yeah.
Mine was 51.
Anything over 300, I believe they consider high.
Yeah. Okay. That's what he just described it as just mild, very mild calcification.
You
And
remember
did
the
not
score?
51.
51?
Yeah.
That's very low.
Yeah.
That's great. Mine was like 890.
Ow. Well, there's also a volume now. I don't know what that is, but that's a total coronary artery calcium volume, 72 cubic millimeters. Oh, don't know what that means. But anyhow, he said it was good, so I'm glad I did it. I'm ready to. And then the other news is I did hit the point for getting my PSMA PET CT. It just went over 2. And so I called right away. I sent them on a message on the portal, the Mayo, and I'm all set and leaving tomorrow to head up to Phoenix to get my PSMA PET CT, and we'll start and see what's growing where.
Dennis, it
That's
went over 2 or it went over 0.2?
0.2.
No,
0.2.
2. PSA
2.
2.
Okay, thanks.
Yeah.
Is that what you agreed? Is that
Yeah.
what you agreed with
That's
the
what
doc?
that's what we agreed to last year when I saw him.
Okay.
Both
Okay.
oncologists agreed to that. So I know a lot of guys
Okay.
go earlier, but oh,
Okay. Yeah. I mean, certainly when it got over about 0.6, that you could probably see something. But if that was the deal, I think that's fine.
yeah. Okay.
So
I'm heading up and I'll have some more information. I'm sure this is just step 1. And the other thing I like to have them do, it's been over 3 years since genomic testing. And that was done with Caris. And there were a few of the mutations that the results came back as indeterminate. That's when that was from the prostate tissue. I still have the prostate, so.
yeah, with a PSA of 2.0, I think you probably would get a pretty good result from a liquid biopsy right now from just taking blood. If it were me, I'd probably send it to Tempus, but find out who he's going to send it to. But if if you can get him to send it to Tempus, that's a good option.
Okay.
All right. And anybody else? Dr. John, did you want to say anything about the heart issues?
No, I don't think I have anything to add there. My calcium score is 400, so I'm sort of in between the two guys that have just spoken, Dennis and Len.
So pretty active, and I'm back to playing golf, and I'm walking every day when I'm not playing golf, and weights about 3 to 4 times a week. So just going along, cruising along here. Watching my diet, that's the other thing too. We do.
You're playing golf in Phoenix? You're living in Phoenix and playing golf now?
Tucson.
And you're able to
So
play golf?
we go out at early in the morning, 6:45 or so.
4 to 7.
Right now, I'm just playing 9 holes.
Wow. 4 o'clock. That's before the lights come out.
No, it's a 6:44. 6:44 a.m. we go out.
Oh, 6:44. Okay.
Yeah. Yeah.
Okay, good for you. That's terrific.
And I get my exercise, even though we use a cart. We're going to play a course here. It's right near where I live, and it's called the Quarry Pines. And it's actually an old abandoned gravel quarry. So it's got lots of ups and downs and hills and stuff that you still have to walk and climb, So that works me out.
Okay, we got to keep moving here. And Dr. John Ayo is up next.
Thanks, Rick. Well, I've got some crazy numbers going on here. As you guys might remember, I started this journey last December with a PSMA PET scan, and then my PSA was, less than 0.1 for 2 years. And then in January, I got on Nubeqa. It was at 2.1 when I started. It went down to 0.5, and then it went to 1.04. These are once a month. 1.6. It went to 4.9 in May. So we added Orgovix, and it went to 35. And then the middle of July, it went to 57. So I did the test. My guy picked Gardent. I didn't catch him. I don't know why, but we talked about it. And he said, yeah, I know there's variabilities in all of them. I picked this one because of your germline testing that came back negative. And he said, we could look at other ones too. So I did a PSMA PET scan on Friday. And so, I had lymph and bone metastases, and the lymph has gotten better. It says interval resolution, and the bone has not. It's gotten a little bit bigger and more metastases. So that's where I am at the moment.
Okay, so you said your PSA was now 50 something, did you say?
57, yep.
57.
And
And this is the doctor at UTSW that you're seeing, Wang?
yes.
And what does Dr. Wang think you should do?
Well, he's suggested chemo, PARP inhibitors, Pluvicto. He's very open because he knows where I'm coming from a natural perspective on this. So the other thing that's strange, and I don't know if this is related at all, is the left side of my tongue partially has gone numb a little bit. And I don't know, again, what the Orgovix. Right now I stopped with Nubeqa because he's like, it served its purpose. So I'm still just doing Orgovix. But man, that is bizarre that my PSA went that high that fast. Because it was only 12 is the highest it ever got before my surgery.
Right, it is really bizarre. And I don't really know why you would stop the darolutamide. You might want to switch to something else and see if you respond better, but I can't see why he would take you off of a doublet. That doesn't make sense to me. That's the first thing. I do think that he's right in suggesting chemotherapy or a PARP inhibitor. Len, do you remember that research we looked at? Should the PARP precede or follow the chemo? Didn't they say precede the chemo?
Precede chemo, yes. However, it wasn't clear if reversing it would make a difference.
Mm-hmm.
Because they didn't run any studies with the reverse. They just compared it to those who had chemo or didn't have chemo and then had
right.
Yeah.
Right. Did you have any germline? As far as I remember, I have a note you didn't have any germline mutations.
Correct.
Is that
right?
Is that
No
right?
germline. The only thing that came up was the BRCA on the Gardent test.
Well, the one thing that the reason why we go to a PARP inhibitor first is because it can revert to wild type. So it's like, do the PARP, strike while the iron is hot. If you got the BRCA2 there, go for it when you see the BRCA2. It can drive your blood counts down, as you heard from Frank Fabish, but that was the take-home message. It was in, I'm pretty sure it was in my one of my slides from the ASCO. So you could go back and look at the ASCO slides. But the idea is do the PARP inhibitor when you can do it. Don't delay on doing the PARP inhibitor. The other thing I would do, John, and I said it a few times, is I think I would get a second opinion because something weird is going on. It's not what we usually see. And I definitely feel like we need to be taking a wider look. I have, from that Guardant study, I have you with BRCA2, TP53, EFGR, MYC, MYC, and AR amplification. I personally would get your butt down and do a consult with Dr. E.
Okay.
I mean, she's especially good on this type of situation which is not run of the mill. And
So,
I'd like to see what she suggests. Now, then you have to balance it with Wang. I don't know how he'll feel about that, but let's cross that bridge when we come to it. But let's see what he says, because I'm not super comfortable with what with what's going on, and I really would like to see you go to a doctor that we have a lot of confidence in.
okay. Well, I just don't understand why the PSA would be so variant with that ADT. Because, like Joe, I've tried to avoid it as long as I could, but then I got on the Nubeqa first for a few months and everything was okay and it was inching up, but then that Orgovix just, man, it shot up. What does that mean?
Well, the sort of the person who might know what that means is somebody like a Dr. E.
Okay.
And there are other docs like that too that we could send you to in other parts of the country. But the fact is that it's not that far for you to get down to Houston. And if I remember, I'll try and mention it to her when I see her, because I'll see her a few times but I think that if anybody can figure out what that means, she's probably one of the few who can.
Okay.
Anybody else have any input on why the PSA should go through the roof when you start a androgen deprivation drug?
No, I don't, especially since it's an antagonist.
Yeah. Go ahead, Dennis.
Was that a tumor flare? Is it just starting ADT?
Yeah, tumor flare.
No, because he took an antagonist and not an agonist. He took Orgovix, which immediately reduces your testosterone rather than pushing it up before it goes down. So he took a drug like Firmagon. Orgovix is like Firmagon. So there's no tumor flare but a good thought, but there is no tumor flare with Orgovix. Okay, do you have the contact details for Dr. E?
I do. Yep, I do, Rick. Thank you.
Okay.
Well, it's good and bad to stump this group.
Yeah, well, there's something going on, and what I would say is don't hang about on it, and probably try and get an appointment with her quickly, just in case she doesn't agree with the PARP inhibitor.
Yeah. Well, PARP inhibitor really is oral chemo, right?
Yeah. But John, I will say, and I know that you guys, especially you as a naturalist, holistic doc, you want to avoid
Naturopath.
naturopath. Thank you very much. Thank you very much. I was struggling, and as usual, Dr. John came to my rescue. As a naturopath, um, I know you don't want to do the drugs, but John, if it were me, I wouldn't be hanging around on this. I would like try and get to this quickly. Um, and if you need any help getting a quicker appointment with Dr. E, just let me know, and I will be happy to lean on her in the office to get you in quickly. But I really would like to see you get down there real quick, like next week, if we
Okay.
could get you. Okay, and use the AnCan. Tell them, use the AnCan name. Tell them you're coming from Dallas. Second opinion.
Okay.
Your PSA just shot up from 13 to from 4.9 in May to 57 and you really need a second opinion desperately.
Okay. Thank you.
Okay, and reach out to us if you need help. Okay, I'm moving along, and next up is Dr. John.
I was a no on the list, Rick.
Oh, were you?
Yep.
Okay.
I just saved you 5 minutes.
Yes, that's a freebie. Thank you very much. All right. And the one after that is the gent who is now looking like a real naval officer, Captain Fisk. You're looking the part now, Captain. Even though you don't like us to use Captain, we've got to use it when you're looking so seaworthy there.
Well, actually, it's for a play that I'm in. I'm a member of the British Explorers Club from the late 1890s, and a woman has the temerity to want to join the club. So it's the Little Theater of Alexandria.
Sounds familiar. I think they just went through that about 2 or 3 months ago in one of the clubs in London, and it caused a huge stir.
That was a good accent.
My question has to do with genomic testing, or a couple of questions. How long could I expect a military facility to hold tumor biopsy samples? It's been going on 2.5 years, and the question is, would they still have the sample available for genomic testing?
Yes, I think.
Well, I would agree with Dr. John, except that I would suggest that it's not going to give you a current result because you've been on treatment. So, it's all well and good doing tumor testing on old tissue, but if you've had a bunch of treatment in the interim, the result that you had then may not be the result that you get now. So I wouldn't necessarily
I've had the external beam, high-dose brachytherapy, and 21 months of ADT.
So right now, your PSA, I'm assuming, is not measurable, correct?
Correct.
Okay. Why are you wondering about getting a genomic test right now?
Listening to a podcast with a fellow named Dr. Ted Schaefer, and he has to do, among other things, with something called a Decipher test, which is apparently a genomic test for high-risk prostate cancer that gives a score on the likelihood of recurrence and severity of recurrence. Or am I just amusing myself?
You're amusing yourself. It's a test. Is Causley still with us, or did he jump off yet? Oh, he's still with us. Are you there, Causley? I knew there was a reason why he should be with us. Well, he's not switching his camera as much, so he might have stepped away. So Decipher, Alfredo can probably address this too. So let me just tell you, and then I'll go to Alfredo. Decipher is a test that's used frequently for men who either are trying to determine what type of treatment they should get, or just have had some sort of recurrence and trying to figure out if if they should be starting hormone therapy and if they're going to be receptive to it. Where you are, a Decipher test isn't going to tell you much. Ted Schaefer is how should I say this? He's not one of AnCan's preferred doctors. He's a urologist who runs the show at Northwestern, if I'm not mistaken. And Jim Schrate has a lot to say about Ted Schaefer. And again, it might be very helpful for people who are deciding what type of treatment to follow with early disease. But for a man who's already been through what you've done, I don't think it's going to tell you very much. You don't need it.
Okay, I thought it was potentially useful for gauging possibility of recurrence, but sounds like I'm just reading it wrong, basically.
I think it's used for it's used to test after a radical prostatectomy to look at the likelihood for recurrence. But in your case, let's
Just
see,
radiation.
You only had radiation, so I don't think that it's. I'll open it up. Len's probably better than this because he moderates a group for all comers. Alfredo has something to say. Go ahead, Alfredo.
Well, I'm hesitant to comment on Decipher specifically. I can verify that Dr. Shaver is at Northwestern. I'll just tell a very quick story. Back in 2014, I had an MRI guided biopsy, not a trust biopsy, an MRI guided. I thought that was fantastic because the doctor could see in real time exactly where he was putting the needles anywhere in the prostate. And one of the things we did is we sent that tissue off to a company in California. I think it was called Genomic Sciences. And they sent me back a very nice looking report. And it said on a scale of 0 to 100, my risk of prostate cancer was 9, extremely low risk. And of course, it was a proprietary methodology based on looking at something about my DNA. Well, since that time, now we're 10 years later, I just have to summarize by saying I've never found a single physician who has found that report useful. Urologists, internists, oncologists, they all just go, uh-huh. And the company, Genomic Sciences, has traded several times to other organizations. So I can't say there's anything wrong with the test, but I can say, just as a kind of a little bit of a warning, that something that I was very excited about. Oh, good. This is going to be a DNA-based measurement. Turned out to be sort of a big whoop. And to this day, it has not served any purpose in my treatment.
So,
Okay.
Len, if Richard Fisk came into your group and he just completed radiation and adjuvant hormone therapy, and he said, "Should I take a Decipher test?" What would you say to him?
The Decipher test is usually done with guys right after biopsy with low or intermediate risk prostate cancer to see if it's likely that they will need a more aggressive treatment plan. So, of course, the higher the score, the more likely it is that the disease will progress and more aggressive treatment is called for. I think it's a little unusual to do it at a late stage like Richard Fisk. What, Richard, are you intermediate risk or what's your?
I'm, excuse me, 4 plus 5.
Oh, that Decipher is useless for you.
Okay.
You know you have, as do I. you have aggressive disease. I'm also a Gleason 9. Decipher is a useless test for you. It can't
Okay,
possibly give you any useful information.
I was hoping to get some sense of likelihood of recurrence, but it sounds like none of these tests are worth anything as far as that.
Well, I mean, that's not strictly true. They are, and the Decipher test has value. So does some of the Polaris and some of the other ones, but not in your situation. I mean,
I'm too late in the
Decipher is
game.
right. Decipher is also used extensively right after, immediately after surgery. It has I think it has an FDA-approved use for testing tissue taken during a radical prostatectomy to tell people how likely it is that their disease will recur, so they can make a decision whether to do adjuvant therapy or not. But that said, and it's also used, like Len says, early on, but there are doctors like Schultz who think that it's a waste of time using Decipher because it was really based on, it was validated at a later stage. It was validated post prostatectomy. But for you, it doesn't have value. Dr. John, what have you got to say?
Oh, this is just quibbling a very small point. I think that Decipher is trained against the chances of metastasis, not recurrence.
Okay.
It's a small point, but
Okay.
I think that's what it's meant.
And Jim Marshall, quickly, what have you got to say? Because I'm watching the clock here.
Yeah. The thing is, I kind of disagree because I believe that understanding your germline mutations and somatic, essentially at the time that you are told you have it, would provide value down the line.
Well, germline, yes. Your germline mutations, absolutely. But your somatic mutations, no. I mean, well, I don't know what you're basing that on because the somatic mutations change with treatment. And so I don't see.
Well, actually, yeah, they might change with treatment, but don't they determine treatment or could determine treatment?
Well, they could, but not from the time of biopsy, and then from the time biopsy, they can't be compared to post hormone and treatment and radiation.
Oh, okay.
Because the radiation and the hormone therapy have changed too much. So it's not going to tell you much somatically.
Well, a germline is of value then. Everybody agrees that, right?
What's that?
Germline testing
yes.
is good.
Yeah, but we're not talking about, forgive me, Jim, but we're not talking about germline. We're talking about Decipher, which is a somatic test.
But originally he said getting genomic testing, which I believe
we're not talking about germline. We haven't been talking about germline. We're talking about Decipher. Germline isn't even in this. You just introduced germline to it. Okay, we haven't been talking about germline testing. We've been talking specifically about taking tissue and testing the tissue, because that's how he started with the VA. Would the VA still have my biopsy samples?
I just want to chime in real
Yes.
quick. I had a Decipher test, and it was very useful. It will determine if you need ADT or any aggressive treatment. I think the Decipher is very useful. It gives you
When did you have it, Henry? When did you have it?
I had mine about 6 months ago. I think it was 6 months ago, after my RP surgery.
Right. So that's exactly what we said. It's very helpful if you get it at the time right after your surgery.
Yes.
But what Richard Fisk is talking about is getting it 2 years after his biopsy, since after he's had radiation and hormone therapy.
Yes, that could be a problem.
Yeah, the
So,
question is answered as far as I'm concerned. Thank you very much.
okay. Michael McCabe, you wanted time and now you're leaving. You gotta give us 2 hours, especially if you come in
Oh,
later.
okay.
Okay?
I'm,
But or tell us, or you can tell us I gotta leave by a certain time so we know to get to you.
oh,
But the
okay.
meetings go on, these meetings go on 2 hours, and especially when we have a lot of people. But I moved you up. What's on your mind?
I just wanted a quick little update, and I will have more. As you know, I'm going down to the Carbone Center this month, um, and I couldn't get in to see Josh Lang soon enough, in my opinion, but I still would like to. I'm going to see Dr. Lou. I believe I mentioned to you, Rick,
Right,
at the Carbone Center,
right.
and one reason I'm really struggling is, yes, I had depression before I was ever taking any ADT or anything, but I really have been struggling with it badly now. So I'm really, in a hurry to get down there. And I think you mentioned palliative care or whatever, but I need something. Where I had been in Green Bay, they just weren't, there was no help for that. There, I am taking an antidepressant, but it's not cutting it. And the only secondary medicine was Zytiga, and I had a lot of trouble with it. And that oncologist wouldn't let me, didn't agree with taking one pill with food. He wanted the 4 pills on an empty stomach, and we just went round and round and round. And so anyway, that's why I'm going down there. But like I said, right now I'm just struggling with that, and I
Okay.
hope.
Are you? Well, we will visit with our two psychiatrists in the group tonight momentarily. But are you still taking the abiraterone?
No, I'm not, because
Okay.
I couldn't sleep. I had night terrors with it, so I'm not taking it at all. So I'm taking Firmagon monthly is what I'm doing at the current time.
Okay. So Dr. Glenn Liu he gets good ratings from everybody we know that's seen him.
Okay.
One thing I will say to you is once you start with a doctor in these centers, it's very hard to change, to switch. So
Okay.
don't think that you'll be able to switch. You probably will not.
Okay.
Um, but you're fine with Dr. Liu. We've had good people. We've had many people talk to him, but in terms of the in terms of the depression, Dr. John or Dr. Jack, I'll come to both of you. Who would like to go first with some words of support for and suggestions for Michael?
I'm not sure what the question is.
Well, he's struggling with the drug that he's on right now. He's seriously struggling. Abiraterone made him worse. The antidepressant ain't working. He's not
There,
happy with his.
yeah, there was no help where I was. I am switching down to the Carbone Center with Dr. Liu, and then hopefully a whole team. And I would have liked to got in sooner, but as soon as I can get in down there, I believe it's the 18th or 19th of August this month. And I don't know what else I can do. I am really struggling with it, but that's kind of where I'm at right now. It's just every moment is a struggle. And
Has the depression gotten worse since you started on the hormone therapy?
it didn't in the beginning, but it is now. The last 2 months, it has now. It's gotten worse.
Does that tie in with adding the abiraterone or not?
What tied in with that was severe night disturbances, night terrors that I couldn't wake up from.
Right,
And
but what about the depression?
um, well, right now I could say that that's not related to it because I haven't been taking it for probably 3 weeks, and it's bad, with just a Firmagon, it's bad. So
Right.
I guess I'm thinking that they need to help me with something else, and there was no help in Green Bay here, there was no.
Right. So the advice that some of the advice that we gave Michael in the past was that he needs to invoke palliative care when he
Hmm.
gets down there, so that they can help him with the psychiatric meds. I mean, Dr. Lou is not going to have expertise in that, but there's probably going to be more of a team approach. Dr. Jack, what any anything you'd like to say to Michael?
It's such a complicated situation when I know so little about him and what's going on that's driving his depression and what medication he's taking that's not working and whether or not,
Sertraline. Taking
what,
sertraline. Sertraline.
sertraline?
Yes.
So how much are you taking?
I believe it's 1,000 milligrams. I'd have to
No,
look
no,
at that too.
no,
Yeah.
no. Not sertraline.
What is it?
Zoloft doesn't come
Zoloft.
in that.
Yeah, Zoloft.
Yeah, but
Zoloft.
that doesn't come in 1,000 milligrams.
Okay,
So
must
you're
be.
taking
My wife
25,
is
50.
she's gonna check, so it must be less than that then.
Well, however long you've been taking it, if you've been taking it for a long period of time, you've had an adequate dosage. If you can't go any higher, you have to either consider switching it up or adding something to it that may make a difference in augmenting the effect of the medication. But it's something you have to talk to somebody in details. It's not a simple answer.
Yeah.
It's a whole process you have to go through, and it takes time to figure that out. I couldn't answer it. Maybe you can, John.
No. What Dr. Jack is saying is exactly standard of care. So you have to find out if the sertraline has been given for an adequate time or an adequate dose. If
It's
it
200
has,
milligrams, by the way. I was wrong. It's
well, that's
200
the full
milligrams.
dose then, and
Yeah.
so you can't go any higher. So you
And I've
either
been
have to
taking
add
it for
something,
quite a while.
you have to either add something to it or change antidepressants, just like
Yeah.
Jack said.
Okay. So I just wish it could be sooner. That's all I can say, But
Probably the fastest treatment for depression would be some of the non-pill methods like ketamine or TMS.
and where would I go for that? Like, I haven't
You
heard of
need
that.
you need experts for both of those things. So
Okay.
you have to find a psychiatrist
Okay.
post haste.
Yes. Well,
Yeah.
thank
The
you.
other, are you seeing a psychiatrist in Green Bay?
There is no one. No, there's no one. My insurance has looked, and there isn't anybody.
Well,
There's,
the other thing that can be done, and you can talk to your insurance, is you can certainly get a video meeting with a psychiatrist.
okay.
Have you looked into that?
I believe they've looked into everything, and there's a shortage in this area. Don't know what the
Yeah, but
deal all is.
the video meetings are from people who are outside of the area,
Okay.
and then you can, and you should talk to them right now, because I wouldn't necessarily rely on the palliative care, yes, but whether they have expert psychiatric care at Carbone, I don't know. It's an oncology center.
Yes.
So what you need is a psychiatrist who understands hormone therapy.
Okay.
And what I would suggest you do is call up your insurance in the morning and say, I need a video appointment with a
Okay.
psychiatrist. And
Okay.
they will tell you who you can see and who can prescribe, and then you'll have a video appointment with the psychiatrist. And from there, you can work with them and you can work with Carbone.
Okay. Yeah, I like that.
Um,
That's something I can do.
but I can tell you, because I know of somebody in my family who just set up a video appointment with a psychiatrist.
Okay.
And my guess is that if they set you up with a video psychiatrist in the state of Wisconsin, they'll be able to prescribe for you.
Okay. All right.
So,
I'll do that, Rick, tomorrow morning.
okay,
Thank you.
so that, and if you don't get anywhere, come back to us. We'll brainstorm again. Okay.
Okay. Thank you guys very much.
Okay. So I'm
Jeff,
going back.
Rick, Jeff has something.
Oh, I'm sorry, Jeff. Go ahead.
So when you were taking the abiraterone, were you on steroids?
Yes, I was.
And are you still on prednisone, or
I know I'm not.
how long ago did you get off it?
It's pretty abruptly after it. I've heard from you guys in a group that's supposed to be kind of tapered off, but I was never told that. So I just stopped that I stopped it almost at the same time, if I remember right.
Good point.
And
Good catch, Dr. Jeff. Good catch.
How long ago was that?
I would say probably 3 weeks now. When I quit. Yeah.
And how much prednisone were you taking? 10?
Yes.
So, I mean, prednisone can definitely enhance depressions, no question about that, and make your sleeping patterns all crazy. And but what's of more concern is you abruptly stopped it. You know, you may not be having enough steroid now being made by your own body, which is kind of a dangerous circumstance.
Yeah, they just never said nothing about that, and I didn't know nothing about it. I
Well,
don't
you
even have.
did because come on, Michael, we've talked about it here, as you said.
Yes, that's right. That's correct. That's correct.
So, but I
I just
really
figured,
endorse
yeah, I
Dr.
figured
Jeff.
since I quit it, I'll just quit that. And then I did hear about that later from you guys, but I'd already quit it. I figured so it was too late
Well,
to go back on it.
we talk about this prednisone all the time and say you gotta taper, you gotta taper. It can be really dangerous not to taper. And what I would suggest you also do tomorrow is talk to your PCP about immediately about maybe you have to resume a small dose of steroids, because that can be really nasty.
Okay.
Have you
Okay.
lost weight?
Yes. But I've also been taking Zepbound for that. So, because I want to
Oh,
lose weight. I've lost 100 pounds so far.
Okay. Well, again, I get with your PCP tomorrow and tell him you didn't realize, they didn't tell you, and you stopped it, and you shouldn't, now you shouldn't have done. And
Okay.
okay, and Gary Peters just put a link for you, with respect to video counseling
Okay.
in the
Yeah,
Thank you.
chat window.
Thank you.
Michael, they will do virtual sessions and they take a number of insurances, and they'll do a free video consultation with you to see if uh, if there would be an arrangement that would work for both of you.
Okay. I've got 2 insurances, so I'm covered that way. So
Okay,
it,
well,
it's a matter of getting
you
the
know,
help.
I just want to say to everybody, please don't self-medicate. If you're going to make a plan to do something, talk to your doctors about it. It is so, so important. And do it with your doctor's knowledge. Because, I mean, I've seen what stopping abruptly. I don't know how long were you on the prednisone for, Michael?
Um, let's see. Probably altogether, I think it was like a month or so, something like that. It
Well,
wasn't. No,
Fortunately, that's not a huge amount of time, but it
Mm-hmm.
still may have had an impact.
Okay.
But so it's not as bad as it could be, but
Mm-hmm.
it could have an effect, and you just need to be talking to your docs about it if you're going to do something like that. We got to move on
Okay.
because
Thank you.
we've still
Bye.
got
Yeah.
1, 2, 3, 4, 5, 6 people. We're going to be going for a while here tonight. Please don't hang up. Stay in the group. We'll get to everybody.
Yeah.
I
Thank
will
you.
stay on as long as it takes.
Thank you.
Okay. Alfredo.
Just a couple of quick things, although I'd have to say I just added another 30 seconds. I want to put in
Okay.
a
Well,
plug.
we don't want you to add. Save it till next week, please.
Okay. I want to put in a plug for primary care doctors. And so, Michael, if you have a PCP, that you can just keep him informed about all the complexities and all the different specialists, I think there's a payoff there, having somebody who can help you coordinate, even though it might seem like they're not directly involved. 30 seconds on my own care. I'm way behind almost everybody here. I'm a full 2 weeks in to my androgen deprivation therapy on Lupron and Casodex. I guess it's going okay. The main symptom I have is just tremendous fatigue, as I know you've all noted. And then the last thing, and Michael, and I'm within my minute or two, is I consulted with my radiation oncologist 2 weeks ago. We several people remarked, "What? You're starting Casodex and Lupron on the same day? Oh, that can't possibly be right." And the response from MD Anderson was, it's correct for people with metastatic disease, particularly prostate cancer in the bone, that those people get started on Casodex 2 or 3 weeks before the Lupron. But in my case, my cancer seems to still be confined to the prostate. And for those patients, they often, usually, I guess, start the 2 drugs on the same day. So I just wanted to report that back to the group.
Yeah.
That's it, Mike.
So there were recent studies, and we did follow up, and there are recent studies that suggest that if there's no clear metastasis, you can start them at the same time. The problem and the reason why you usually start beforehand is because a lot of times we can't see the metastasis. And so it's more conservative to start them early. But if it were me, I'd be wanting to start ahead of time. But we know where it's coming from now because there was a recent study that said you can start them at the same time. So we get it, but I don't think we'll change our view that ideally you want to start it early because that's a more conservative approach, and I don't see what the downside is to starting it early either. Do any of the moderators want to comment on that?
Yeah, agree.
So thanks, Alfredo. Yeah, I mean, they have a reason to do it based on recent studies, but do I personally think it's a good protocol? No.
I appreciate
But
that.
I'm
Thank
not.
you.
Sorry.
I appreciate that. Thank you very much. I just wanted to share what MD Anderson had to say.
Yeah. Okay. Anybody else want to comment on that before we move on? Okay. Hold on a second. I'm just making notes for writing this up tomorrow. Okay. Who are we? Who's up next? Phil Houston.
Hi, I don't have too long. I'm fresh into it, a little bit like the gentleman that just spoke. I've started the Casodex for a couple of weeks, and then I had my Lupron. And again, like everybody else, repetitive, tired. They've got me on. I got somehow your Bear Foundation has me on Nubeqa. I've gotten approved to the end of the year, and I'm on Eligard. Everything seems to be going along well. I'll have another meeting with Belushik, and he seems the group in Miami at the Sylvester Center seems really good. Don tells me I can go there for everything. Psychiatric says I can go down there and get a massage if I want. But other than that, the next trip is Belushik in the end of August and another Lupron shot in January. Pretty much that's it. I'm in a palliative situation, and we'll talk about radiation. I guess I'll talk with them in August and talk about something in January. Seems like I have some in my shoulder. They don't know what it is, but also I did not go to a second opinion, but I have a school friend whose wife is named Slovic from Sloan Kettering, and some of my urologist heard of her. And we talked about it. The only thing she said, she couldn't disagree with what we're doing, as we had cheesecake at the Cheesecake Factory. She said the only thing she likes Zytec better, and that's all. That's all I have to report. Other than that, she said I'm on a good program.
So wait a minute, I'm a little bit lost here, Phil. You've seen Belusic, correct?
On the 5th of July, and then I started on Casedex for a couple 3 weeks, and then I went to again a different location, and they put the Eligard in me and started. I stayed on the Casedex until I guess it was last week or so. They approved the Quebec, and they mailed it to me, and then they told me I have it approved till the end of the year.
Right. So
I don't have any bad effects except constipation. That's it. I'm
right.
tired.
So right now you're on Darrow plus Eligard, and that is Belusic's recommendation, correct?
Yes. Yes.
Okay. And then you're going to follow up and maybe talk about radiating the primary tumor.
I think he says we'll talk about that probably when we do it in January, but we'll talk about it in
Right.
August. He's not sure how far aggressive we should be. I think when he talked about it, he says if you get really aggressive, you might die from the treatment as opposed to from a heart attack or something. But we were talking about chemo and radiation, but we were just talking generally. He has
Okay.
no firm feeling on it now.
Now, how long so far have you been on the Casedex and the Eligard? You're Eligard or Lupron you're on?
Well, it's Eligard is what it's called, yeah.
Okay. How long have you been on the Casedex and the Eligard?
The Casedox was for about 2 weeks, and then about last week, I think it was last Wednesday, I started on the last week. I started on the
Eligard. So you've right. So you just started the Eligard, right?
right, and now I had that about a week or 10 days ago, and then I went to the Nubeqa last week when it got
Right.
approved.
So you'll start to feel the impact of these drugs pretty soon. They take a while for you to notice them, largely because of the way they work, especially the Eligard. So the first couple of weeks of Eligard, you feel great because you're actually putting more testosterone into your system before it shuts it off. So,
okay.
and the reason you took the Casedex is to protect you from that extra surge of testosterone, right?
Yes,
Now,
sir.
so come back to us and we'll help you as you start to feel some of the side effects. Are you exercising daily?
Not as much as I should, but I now that I listened to everyone tonight, and Don has been telling me exercise, I will become a religious believer. I am a religious believer now.
Okay, so you've got to exercise daily. You've got to mix it up with aerobic and weights, both aerobic and
Okay.
weights, really important. We'll help you again with the exercise. There's information on our website. There are a lot of guys that can instruct you. Don can hold your hand on that, but start doing it immediately. Don't wait. Don't get behind the 8 ball. Okay,
Yes,
one of
sir.
the things that's going to happen is you'll start putting on weight around your middle if you don't. Okay, you're going to get hungry all the time because that's one of the effects. Be careful what you snack on. Have plenty of carrots and celery and that type of stuff around. Okay, be
Okay.
real careful. The guys can, again, we're running pretty late tonight, so we can't get into it, but come on next week. And I think Dr. John has switched with Ben, so Dr. John will be here and ask about how do I deal with the impact of these drugs, but they don't hit home right away.
Okay.
Okay, if
Well,
you start to feel depressed, it's the drugs, and we'll talk to you about what you can do. There's a whole bunch of things that are going to happen. But that's the nature of the beast. Len or Dr. John, do you want to add anything to that advice for Phil, who's just starting?
That sounds really good to me. The main question in my mind is that once he got to Belusic, whether he was going to consider him for triplet therapy or not. And I guess that probably considered him low volume and went with the doublet therapy. I think it sounds like we're right on track.
Phil, are you
Len?
on Medicare?
pardon?
Are you on Medicare?
Well, God bless you. I just turned 83.
Damn, you look good, brother. Well, yeah, because I'm just wondering, I had a hell of a time getting darolutamide, Nubeca, even though I was on it previously and it was working fine. And in fact, my insurance, I'm on Medicare, and my insurance refused to cover it because I wasn't also taking chemo. And yet you just got approved, no problem,
Yeah, they
without
just changed, Len, they just changed the approvals just recently. Within the last month or so, they've added hormone sensitive prostate cancer as an eligible category for Nubeca, darolutamide.
Okay,
I
even
was
though they,
surprised because I got approved like in a weekend, and in a week, and I had sent them in my tax return. I said, I'll never get approved. And they called me 24 hours later and said, at the end of the year, you're good. I thought it was crazy.
crazy
Maybe,
good.
I mean, the social workers, as Don will tell you, this Sylvester, they're on top of it. They're turning this stuff around, and it's like in a day I had one, and 3 days I had the other. So maybe you ought to reapply.
Well, I'm getting it free from Bayer, as it turns out, but only till the end of the year, like you. Anyway, I don't want
Okay.
to hold up the
Okay.
group.
Yeah, and Len, look in. I think it was sometime either in July or August. Check the old reminders, but I did mention it in the reminder. I think I put it in as a breaking news right at the top
Oh,
that
okay,
hormone sensitive is now approved. If I have
great.
time, I'll look for it, but it is there. All right, we're moving on. Andre.
Yes, hello. It's been a couple meetings I missed in that time. It's been 3 months. I've been on Casodex to start, and then another 2.5 months of Orgovix. My PSA went from 15 3/4 down to 0.03, and I went in last Wednesday for the high dose brachytherapy, which was pretty seamless over at Moffitt in Tampa. I see my radiation oncologist to start the planning for the IMRT this Thursday, and should be going through 5 weeks. So everything seems to be going well. I did hear some of the commenting on the side effects, and the Orgovix has been great for me. I am tired though. We had the hurricane kind of buzz by us here in Tampa, and I was out picking up storm debris and felt kind of, you know, out of it. My doctor says the only exercise I can do for the next 6 weeks or more is just walking, and I have to give up the weight training and anything with pressure because of the I guess from the brachytherapy they don't want anything to complicate things there. Question I have is the ADT. My cancer by PSMA PET scan is shown it was contained in the prostate, but I guess there's always chances of metastasis, undetectable metastasis. So does ADT knock out those lone rangers that may be around in the bloodstream or wherever they're at? Is it just put them to sleep? I'm not quite sure about the modality of ADT. If you can enlighten me on that.
Go ahead, Len, or anybody first.
Yeah, my understanding is it is not cytotoxic. It does not kill prostate cancer cells, but it does kind of put them in a dormant state. I imagine maybe some of the weaker cancer cells may succumb to ADT treatment, but I think that the general consensus is that it is not cytotoxic in the same way that, let's say, chemotherapy is, or some of these, precision medicines like olaparib, or the radionuclide therapies.
Okay, so when the radiation oncologist is going to, treat the prostate and the lower lymph nodes down there when he does his thing, and that's a hope it's been gotten. I guess it's just like Mr. Fisk had mentioned before, and I'm probably doing the same routine as him and Rick in the past. I have Gleason 10, so I guess I just have to, after it's all said and done, just wait and see, I guess.
Couple of things I would say. Make sure with your who's the radiation oncologist at Moffitt that you're seeing?
Dr. Johnstone.
Okay, say his name again.
Dr. Johnstone.
John Stone. Okay.
And Dr. Rishi did the brachytherapy. He's another radiation oncologist.
Yeah. So some of them do not radiate the whole pelvic girdle. And what we've seen is that should be the protocol right the way across. Some of them will use other patterns like rabbit's ears and just the bed or what have you. I would, if it were me with a 5+5, I would be making sure that they were radiating right across the pelvic girdle, which is what I got. So I would be asking them, are you radiating the whole pelvic girdle, or are you radiating a pattern? And if they say we're just doing a part of it, I would question them, because the evidence seems to show, especially with 5+5, that they should radiate the whole pelvic girdle.
Okay, he didn't use those terms, but he did say the lymph nodes down there. But I'll definitely bring that specific up this Thursday when I see him.
Well, that's the problem. The lymph nodes down there, you don't know what he's doing. And, if he said I'm radiating across the pelvic girdle, we'd know what he was doing. But I think you have to say to him, this is what I want. I want the whole pelvic girdle radiated. Again, I'm not giving you medical advice, but I am saying to you that's what I got. And where I've seen that people get less, I've seen there's more likelihood for the cancer to recur. And especially when you're dealing with a 5+5. So for me, it would be the whole pelvic girdle. And how many sessions are you getting?
It should be 25.
Yep. I mean, that's the right number of sessions, and hopefully they're going right the way across from one side, from one hip bone to the other hip bone and below. So just verify that. Now, in terms of what does the ADT do? And is it cytotoxic? I agree with Len, but what it also does is it starves the cancer. So if you've got cells that cannot survive, they are going to die off based on not having anything to thrive on.
So that's where they come
So
with 18 to 24 months is for something more.
that's right. That's
Okay.
right. Now, there's a school of thought, and I'm not very good at this one, that now for some people they are adding with high risk T3 like you had, they are adding a second line anti-androgen. Len, do you or Dr. John or anyone else, do you know about that? No. But again, I would discuss it with them. I'm a 5+5. Am I a candidate to add a second line anti-androgen? They are doing it for high risk and very high risk patients. That there is evidence. I think it's even in the NCCN guidelines. I'd have to look.
So
Well,
I'm
it is.
I'm a Gleason 9, and right off the bat it was Firmagon and abiraterone. And they told me, because you're so high risk, I had seminal vesicle involvement too, you go on 2 drugs from the get-go.
Yeah, there was concern with my family history of heart disease that they forego in my calcium scores and other things from my cardiologist. They thought it might not be heart healthy. I can't remember which particular drug they were talking
Probably
along those lines.
abiraterone.
The secondary, so they just decided on the Orgovix for now. It
Yeah, I
seems to be
mean
doing.
that would have been the abiraterone, but then in that case they could put you on a different second line anti-androgen.
Okay, something for
The
me to
aber
ask.
Yeah, yeah.
All right, thank you. Appreciate
Thanks,
the.
Dr. Jeff. Dr.
Can I?
Jeff, do you know, is it only abiraterone they state, or do they state any ARSI?
I think it was plus abiraterone.
Yeah, because I think that was the trial, but they could give you another one if they wanted.
Can I ask him one question, Andre?
Of
Did
course.
you did you say you took Casodex and then Orgovix?
Yes, I started off with Casodex, and I wasn't sure what the next steps were. That was the immediate prescription, and presumably Lupron was coming up, but I wanted to get something more heart friendly, and I talked him into Orgovix.
Okay.
Does he, Rick, you know this best, but do you need to take Casodex if you're going to go on Orgovix?
You don't, but I expect what happened was they weren't going to put him on the Orgovix until he talked them into it.
Uh-huh.
So they set him up on the Casodex, thinking they were going to give him a Lupron shot, and then Andre did a great job talking them into Orgovix, so the Casodex became
For
redundant.
nothing. Got you.
But he'd already taken it.
Right.
Good job, Andre.
Thank you, appreciate it. I'll let you know how it goes.
Okay. Okay, we're moving along. And Dr. Jack, I've got
I'll
three
be very
people
quick.
left. Let me just tell you who I've got left. Well, no, two, because Matt McCabe dropped. Matt McKim dropped off. So, Dr. John, will you put Matt McKim in for top of the list next week, please? Where's
Okay.
Dr. John? Did Dr. John? Is he still with us? Okay, no Dr. John. No, Dr. John left too. Okay, we'll make sure Matt gets in. I got to do that, Dr. John. We got Dr. Jack and Jeff Wood.
Okay, I'll be quick. Okay, I have a question. You know, I'm listening to many people here. Jim Marshall, you are not metastatic, but yet you've been on doublet therapy for 5 years intermittently. And I want to understand if there is a rule, if any, on the amount of time that metastatic versus non-metastatic stay on doublet therapy. Because I hear these figures, 24 months, 36 months, it's arbitrary, it's really up to you, it's very subjective. So I'm confused. I'd like to know if I'm counting on 24 months of staying on the doublet therapy, and I have involvement of a couple of bone areas and my lymph nodes in my lungs. So I wonder if 24 months, is there any rationale behind that? Is there any literature or studies that say metastatic people should take it for life, or can you take it to 24 months, or is it subjective and up to me, and I can do it if I want to have some quality of life and gamble on taking it intermittently and then see how it goes, which is what I'm planning on doing. But I don't know. I'm reading things, hearing things about it's supposed to be the rest of your life. I'm confused.
Well, let's just separate two things. You're asking specifically about metastatic, and I haven't seen much on metastatic intermittent.
Right.
There are guidelines if you're like Andre or Dr. Jeff, if you're getting hormone therapy as adjuvant to radiation up front. That is not your situation. Your situation is you're recurrent and you now have metastasis and you want to know how long you stay on. And I think at that point it's an art rather than a science, especially if you're talking doublet therapy. And I'm going to refer to our expert in that area, Len, because he has done, this is the situation Len has been in, kinda, and he's done more intermittent than anybody I know. So Len, what would you say to Dr. Jack?
Well, I'm guessing that most oncologists would say once you're metastatic, you should not go on intermittent therapy. You should be on hormone therapy for life. I did not follow that advice, and it's at my own peril, my own risk. But like you mentioned, Jack, you want to improve your quality of life, and that's the reason why I decided I wanted to go on intermittent, even though I am metastatic. So my doctor, Dr. O, was okay with me doing that, but he recognizes, he said, okay, you're in your 70s, you have your grandchildren. I understand you want quality of life. Go ahead, go. Actually, I even went on a complete drug holiday after I had been metastatic. So it depends on the individual, is bottom line. I didn't like the way I felt after a while on even monotherapy, Nubeca. After I was on it for a couple of years, I just felt like I didn't have much energy. I haven't taken ADT since 2021, and my PSA now is near undetectable. So this is the way I look at it. You want to see if your quality of life improves, go off the drugs. If you see movement in the PSA, you go back on.
And what about this 24 months? Is that just something in my head, a number? I mean, I can go off it tomorrow. I've been on it for 13 months.
Yeah, it's a good question. I don't, it seems to be generally accepted that, at least 18 months, 24 months, I suppose, even better. But I don't know how much data supports that.
Yeah, I'm wondering
Yeah.
about that. Any studies being done to see whether or not it's going to be more effective in terms of creating dormancy or putting it back to sleep like it was for 20 years with me?
So I don't think the work's been done. I think that more and more there is an acceptance that intermittent hormone therapy works. At the same time, what we saw in the Embark study was that um, those people who did Lupron and enzalutamide did slightly better than those people who did enzalutamide alone, um, even on the intermittent leg. So, but how long you do there in the Embark study, they took people off after 9 months, and they started, and then they would put them back on when their PSA got to a certain level. My anecdotal experience has been you should really stay on it for 18 months the first time you go on it for it to have an impact. Now, there are considerations. In your particular case, you have a non-aggressive, a very non-aggressive prostate cancer. It took many, many, many years for it to even show up. And originally, weren't you a 3+4 originally, Jack?
Yes, 3+4, PSA
Yeah,
3.8,
right. So,
nomogram,
so,
really.
so you don't have a very aggressive form. So if you're going to push the envelope, you're the sort of guy who should push the envelope versus somebody like Andre, who is a 5+5, or Len, who's a 4+5. But we don't have good data on intermittent. I mean, it keeps flipping, and some people say, oh, it's non-inferior, and then they say it's inferior, and then they say it's non-inferior. I mean, how many times has Maha Hussein switched horses on this one, Len? I mean, it's crazy. And there's loads and loads and loads of data on intermittent hormone therapy. There's a lot you can look at on intermittent hormone therapy, and you can probably find some protocols, and I can't tell you them off the top of my head.
Rick,
Yes.
I had a conversation with Dr. E. I've been undetectable for 4 months, and I was talking to her about possibly going off. And she said at the end of this year we'd talk about it. And she wasn't opposed to going on a holiday, but she said she's been burnt twice and she's not going to get burnt again. So she demands that if you go off, or if I do go off, she wants a PSMA test every 6 months. That's her philosophy on it.
Makes sense.
Okay.
Are you
Jim
metastatic?
Marshall. Jim
Jerry?
Marshall.
Yes,
What would it?
Yeah.
yes, I'm metastatic.
Thank you, Jerry.
4+5.
Jack, you said that you thought I was then non-metastatic. I am metastatic.
Oh, you are?
Okay,
Oh,
3+4.
I thought it was just confined to the pelvic bed with you. You've had it?
No, it escaped out to the lymph nodes in the back, and were the big ones, and were the peritoneal, or I think it is.
Retroperitoneal.
But anyway, I am a 3/4. So after the 5 years, I also have ATM somatic, and I believe there was a study that Len found that said if you stayed on Lupron plus the abiraterone continuously, there was a 30% chance of small cell neuroendocrine.
Oh boy.
So it kind of got me thinking about intermittent.
Well,
And that was
that is definitely the case,
my other
because
question I wanted to briefly ask
yeah,
Rick,
well,
whether or not
that's
by taking a vacation, if that reduces your chances of ending up getting a neuroendocrine or getting castrate resistant. I mean, you're
So
going to
it,
get castrate resistant, but you become castrate resistant.
Jack, let me answer because it's
All right,
really
go
we're
ahead.
already
Yeah,
half an hour over
I
and we
know,
still
I
got to
know.
get to Jeff Wood. So you know I can't. We got to.
Okay, another time.
The answer the answer is we believe that if you stay on a drug too long on an ARSI too long, then the cancer gets so used to it that nothing else works. And we can quote several guys where we've seen that happen. We encouraged Dennis Correa to get off and take a drug holiday, which he did, and then he went back on, and then now he's off again. So 5 years is a long time, especially for a guy who's 3+4 and they doesn't have bone mets. But if that's what Jim wished to do, I personally would not do that. I would have come off of it earlier. In your case, we're not talking 5 years, we're talking 13 months. If I was in your shoes, I probably would stick it out to 18 months for good order's sake. And at 18 months, I would think about seeing what happens next and taking a break. That's what I would do. That's not medical advice, but it's what I would do based on what I've seen. But the answer is yes. Don't stay on a second line anti-androgen for too long because you wind up with not having any other alternatives and it morphs. But you're nowhere near that situation. It shouldn't even be in your head.
Well, thank you. I'll
Not,
discuss
it's
it.
not even worthy of a question after 13 months, Dr. Jack.
Thank you.
Okay, can we move on to our... Oh, no, David Muslin has his hand up. Go ahead, David Muslin.
One quick question for Len. Len, what are you currently on now?
Phototherapy with Darrow.
Okay, so you went back on Darrow.
I went back on, but I'm down to just taking 2 pills a day now, so it's half a dose.
Okay, and your
One
PSA
in the
dropped,
morning, one in the evening. Yeah.
and your PSA dropped again, back
Yeah.
to undetectable. Cool. Did you take scans? Any meds show up anywhere?
Well, back in October of 2023, yes, I had a PSMA scan and some bone mets showed up, but that was after a 21-month drug holiday. No drugs.
Did you radiate this? Did you radiate the mets or no?
I kind of wanted to, but long story, I couldn't get medical records transferred to, I wanted it sent to, oh, Jack, you know the name of the guy in Miami.
Pelusic.
Not Belusic, the radiation oncologist.
Oh, got it. Yeah.
Alan. I mean,
Yeah.
Alan.
Yeah, he said he couldn't get the records from Mount Sinai. Why should that be a problem? I don't know. But so anyway, I never got radiation.
And it went back. The PSA went back to undetectable.
Well, it
That's
went down
awesome.
anyway. Yeah.
Okay. How high did you? One last question. I'll stop. How high did your PSA go to?
It only went to 0.2 back in October of 2023.
Right. Okay. All right. I'll in August I'll do another PSA test. I'm right behind you, by the way. So we'll see where I'm at.
Good.
Thanks, guys.
Sure.
So, Len, do you take the DA in the morning and the row in the evening then? Is that what happens on half a dose? I don't know. Yeah, but I like the system. So when was the last time? I have a PSA for you in June of 24. Have you had one since June?
Yeah, I just had one, and it even though I'm on half a dose, the PSA actually went down to 0.02 from 0.03.
Oh, well, I had you at 0.02 in June. Maybe that was wrong.
6 weeks. Okay, so then it stayed the same. I thought it was at 0.03.
Okay, well, we're somewhere now. Now we're quibbling over. Well, we're quibbling over 0.01s. which
Yeah.
is within the margin of error, right, Fratello?
A hundredth of a nanogram, that's pretty small.
That's right. That's exactly right. Okay, we're finally getting to Jeff Wood, and I'm sorry it's taken so long, Mr. Wood.
That's all right. It's all right. This is a similar kind of a question. After being off, I was on ADT for 24 months. First time. Got 4 years of being on nothing. And I just started back on Orgovix in March. Had a great effect. Quickly dropped testosterone and PSA dramatically in a month. And I guess it's sort of the same question, like how long do I stay on this before I consider coming off it again? My local doctor actually wanted me to take Orgovix not daily as recommended, but one pill every 4 days to try to find that sweet spot of suppressed PSA, but not so suppressed testosterone. I'm doing the pill daily as per label right now, so not to confuse things, but just an interesting side note.
And what's your most recent PSA?
Undetectable,
Okay.
less than 0.02.
Okay. Well, again, when you went back on, it was based on your PSA rising, or did we actually? My notes
Correct.
say you never.
Rising PSA.
Any,
I'm sorry?
but we never saw any Mets, right? Nothing ever showed
No,
up.
PSMA came out, no Mets.
And the Axumin, did you get an Axumin at the time?
No.
Okay, so we don't know whether you make PSMA or not. So you could be one of the guys that doesn't make PSMA. That's possible, yeah.
Yeah, I did have an acumen, after surgery, before radiation, and nothing showed up at that point. But that was
Yeah,
that was a while ago.
Yeah, it's sort of maybe a possibility to do an Axumin if you don't see anything at PSMA, and they scanned you when you were at 0.63, I think.
A little higher, yeah, 0.8,
Yeah,
8,
they
9, I think
scanned
that
you.
was.
Yeah, when you got your PSMA.
Yeah.
I don't know. The problem is we don't know what we're dealing with in your case, and that's my concern. And it's probably not a good time to do a PSMA now that you've been back on for almost 6 months. But I think what I would do next time the opportunity arises is definitely to do an Axumin scan. It's also the reason why I guess they haven't put you on a second-line anti-androgen, because they don't really know what's going on. Your local doc, who wants to find the sweet spot for you, I don't know what he's basing that on.
Yeah,
We got to.
he's trying to. I think he's just trying to address quality of life stuff, and I talked to Dana Rathkoff, and she was not for it. She said, I wouldn't do that. I'd take it as per label. So that's what I'm doing.
Yeah. At the same time, you were a 3+4. So, you're another one of these guys that probably doesn't have super aggressive disease.
Yeah. Well, I'm 4+3 cutting hairs here.
Oh, okay. Well, that's helpful, because I did have a question mark after the 3+4. So now I know what you are.
Yeah. Post surgery. Yeah. Post surgery, 4+3.
Okay. I don't know. Anybody want to give their thoughts to Jeff? How long he stays on? And
I just want to get one thing straight. You were 4 years on nothing at all, and then you had a reoccurrence, and your PSA came back after 2 years of treatment, doublet treatment. Is that what you're saying?
No doublet. Over the course of 4 years, I had 2 years of no increase, and then 2 years of increase. It got to almost 0.9. And then after PSMA scan, went on Orgovyx after being on Lupron the first time.
Just Lupron. Okay, no doublet. Okay.
No. It was 2017 prior to, I think, that even being a consideration.
I get it. Okay.
Yeah.
I mean, the fact is now, I mean, you could be on doublet, Jeff. And did you ever discuss doublet with Dr. Radkoff?
Yeah, she thought it was a little too early for that. She didn't think so.
Yeah, okay. I don't know what to say. I mean, I think, how long does she think you should stay on it this time?
I've got to get back with her. Now that I'm on Medicare, I can fully switch over to her, so I'm going to do that.
Yeah. No, she's real good. And just an aside, and I will mention it again, but my old buddy Chuck Ryan, who used to be the president of PCF, is moving to Memorial Sloan Kettering. So we now have two excellent GU medoncs as a choice at Sloan Kettering, as well as all the other ones. Like Larry Fish, well, Larry's left, but like Larry Fish's doc, Karen, whatever, with an A, forget her last name. But anyway, I would have no hesitation in referring anybody to Chuck. He's a great doc. So that's where we are. No real answers, Jeff. Sorry.
Bummer.
Don't know what to say. Keep talking. I think the answer is keep talking to Dr. Radkoff. She's a very good doctor. We like her, and take her and follow her advice. And if you start feeling really crappy, again, maybe you take a break, or maybe you go on a monotherapy. Maybe you switch to a monotherapy second-line anti-androgen.
Yeah.
Monotherapy darolutamide, like Len's doing.
Yeah, right. All right.
David's done that too. David's done monotherapy darolutamide. All right, guys. Boy, this has been a marathon today. Did somebody else want to say something before we finish up?
Did you say that Chuck Ryan is leaving PCF?
He has. He's long gone.
I didn't hear that.
Yes, he left right around the time of GU ASCO in February. I think the following month he stepped down.
Who took his place?
I don't know. I don't know if they've hired anybody. I haven't seen that they've hired. It's a tough job, I mean, you're working for Milken. That is not easy. I mean, I've worked for guys just like Milken, and it takes a certain personality and a certain type of person. And when Chuck went there, I knew in my gut that he wasn't going to be able to handle Milken, but I didn't feel it was up to me to tell him. And sure enough, it was like chalk and cheese. It ain't easy working for Milken. And he has his ideas how he wants to do things, and there needs to be some chemistry between you and him, and if the chemistry ain't there, then it ain't gonna work. And I think that's what Chuck found after 2 years. And I like Chuck a lot, and he's a very, very good doc. So I don't know who's going to take that job. I mean, it's attractive. It pays over $1 million a year.
Uh-huh.
he pays a lot of money to get the person that he wants.
I saw Len's eyes that light up there.
Well, my Dr. O is the chief medical officer for PCF. So I'm going to see him next week. I'll ask him if he knows what's going on over there. But this is public information, and this is why Dr. O told me, he wasn't violating privacy. Milken has been on hormone therapy since, when was he first diagnosed? Like mid or early 90s?
Yeah.
Never took a break, Dr. O said. I said, isn't that kind of overdoing it? And Dr. O said, yeah, I'm sure his testicles are shot by now. There's no way he'll produce any testosterone. I don't know why he needs to be on any drug. But
I think, from what I could gather, I think Bill O and Chuck are pretty close. And I'm sure they'll continue to be pretty close. And I'm sure also that Dr. O is very empathetic. That would be my guess, Len. But it's an unenviable job working for somebody like Milken. I wouldn't want that job in a million years. And it happens to be, I do have some expertise in working for these very high net worth Jewish, exceptionally successful entrepreneurs. But wow. My guys own basketball teams, 2 different teams. One on one team, and then I had another. I worked for 3 of them that owned another team. So it just ain't easy. It ain't easy.
I have to say goodnight, Rick.
So do I.
Good night.
Good night.
All right.
Good night. Good night, everybody.
Thank you, Rick. It's very useful.
Good night.
All
Good
right.
job.
Thank you.